Hello, esteemed colleagues. I am Dr. Abhijit Chatterjee from Kolkata, and today we will talk about a crucial subject. Title: Dysglycemia in Cardiovascular Disease, Unraveling the Best Glycemic Risk Predictor. Introduction. Welcome, colleagues. Today, we'll explore the critical relationship between dysglycemia and cardiovascular disease, focusing on identifying the most effective glycemic risk predictor. This topic has significant implications for patient care and risk stratification. Historical context. Over 2 decades ago, science has made a groundbreaking discovery. Impaired glucose tolerance and newly diagnosed diabetes were common among patients admitted for acute myocardial infarction. 40% had impaired glucose tolerance, and 25% had newly diagnosed diabetes 3 months post-discharge. Norhammer suggested using HbA1c at admission, fasting blood glucose on day 4 or 5, or an oral glucose tolerance test, OGTT, before discharge to identify high-risk individuals. Recent advancements, Giulia Ferranini and colleagues have now taken this research further. Analyzed data from EuroAspire 4 and 5 surveys, 8,364 participants with coronary artery disease but no known diabetes. Evaluated predictive power of fasting plasma glucose, FPG, 2-hour OGTT plasma glucose, 2-HPG, and HbA1c. Key findings. 1. FPG showed no significant association with cardiovascular events. 2. 2-HPG, Shiz 162 megagauge increased cardiovascular event risk, adjusted HR 1.58. 3. HbA1c 5.9% was a better diagnostic value than the current 6.5% threshold. HbA1c 5.9% associated with 48% increased cardiovascular risk, but effect explained by 2-HPG in multivariable analysis. Implications and consideration. 2-HPG emerged as the best glycemic predictor for cardiovascular events. HbA1c cutoff of 5.7% could be a practical alternative. 60-minute OGTT with 1-HPG, 154.8 mg LDL, shows promise for predicting diabetes progression and complications. HbA1c of 5.7% identified a similar number of at-risk individuals as 2-HPG. Scientific insights. Pre-diabetes. HbA1c 5.7, 6.4% carries significant cardiovascular risk. Discordance between 2-HPG and HbA1c may identify distinct risk populations. Some studies show HbA1c may identify fewer individuals with prediabetes or diabetes than OGTT. Cardiovascular risk profiles may differ in discordantly classified individuals. Treatment considerations. Both 1-HPG, 154.8 mg/dL, and HbA1c, 5.7%. Values are below diabetes diagnostic thresholds. A question arises about appropriate glucose-lowering treatments for high-risk individuals with dysglycemia. Cardiovascular outcome trials have shown cardioprotective effects of GLP-1 receptor agonists and SGLT2 inhibitors in diabetes. SELECT trial demonstrated semaglutide-reduced cardiovascular events in obese individuals with established cardiovascular disease, regardless of baseline HbA1c. Conclusion: the study by Ferranini et al. Reinforces the importance of screening for glucose tolerance in cardiovascular disease patients. While 2-HPG appears to be the best predictor, HbA1c at 5.7% offers a practical alternative. Further research is needed to compare 1-HPG and 2-HPG directly. 2. Clarify the concordance between 2-HPG and HbA1c. 3. Determine optimal treatments for high-risk individuals with dysglycemia but without overt diabetes. As we move forward, implementing systematic screening for dysglycemia in cardiovascular patients could significantly improve risk stratification and patient outcomes. Citation: 1. Norhammer, Ateners, and Nilsson, G. et al. Glucose metabolism in patients with acute myocardial infarction and no previous diagnosis of diabetes mellitus. A prospective study, Lancet, 2002, 359, 2001 for 22144, 2, Ferranini, G. Tomilecto, J. De Backer, G. et al. Reden. Dysglycemia screening and its prognostic impact in patients with coronary artery disease. Experiences from the EuroAspire A4 and V cohort studies. Lancet, Diabetes, Endocrinol, 2024. Published online. Septier, 23. 3. Bergman, M. Manco, M. Sesti, G. et al. Petition to replace current OGTT criteria for diagnosing prediabetes with the 1-hour post-load plasma glucose 155 mg DLR 8.6 mmol plus a cell. Diabetes Res Clin Pract, 2018, 146, 18, Share 33.